QC and Histotechnology certified as ASCP. Mr. Abdulaziz, whenever you're ready, you may start your screen.
Assalamu alaikum. Thank you, Mr. Abdul Basit, for the introduction. Actually, it's my pleasure to start the first activity of Cytology Club under the umbrella of Saudi Society of Cytotechnology and Histotechnology. Today, I will talk about troubleshooting technical issues in gynecological cytology in Pap smear. So by the end of this lecture, you will be able to identify problems with Pap smear and troubleshoot them in pre-analytical phase, analytical phase, and post-analytical phase. But before we start talking about the issues and how we troubleshoot them, let's define what is Pap smear. It is a procedure in which a small brush is used to gently remove cells from the surface of the cervix and the area around it so they can be checked under a microscope for cervical cancer or human papillomavirus changes that may lead to cervical cancer. A Pap smear is also useful to find other conditions such as glandular abnormality, infection, and inflammation. So when Pap smear should be done, it's usually done for routine screening, follow-up patients with history, abnormal clinical abnormality such as abnormal uterine bleeding, IVF patients, and for clearance for transplant patients. So to prepare a Pap smear, we have mainly two main methods. The first one is conventional smear, or the old method, and the liquid-based cytology, which includes filtration technique, and mainly we are talking about thin prep, and sedimentation technique, which include sure bath. For the conventional smear, the principle, the sample is collected and smeared directly on the slide by a physician in the clinic. As we see here, if the physician using spatula and endocervical brush, after they collect the sample, they immediately smear it on the slide. And this another way, they smeared the endocervical brush in the left side and the spatula on the right side. Or if they are using broom brush, they smear it from up to down, then they flip the brush and again smear it from up to down and immediately fix it in 95 ethanol or using fixative spray. While in the liquid-based cytology, the filtration technique, after the sample collected, it's rinsed in the solution for 10 times with the swirling to make sure the cells dropped in the solution. Then in the lab, we start by dispersion, the first step, then cell collection and cell transfer to the slide. While in the sedimentation technique, the shore bath, the head of the brush detach to the solution and sent to the lab. Then in the lab, we start by vortex and the disaggregation, then transfer the sedimentation tube, which includes a density reagent. Then we start by sedimentation, and the last step is cell deposition and staining. And the last thing before we start talking about the issues is the patient preparation before taking Pap smear. The first recommendation, avoid collection Pap smear during menstrual period. The best time, at least 5 days after menstrual period stops. Avoid using vaginal creams, lubricant, and douche for 2 to 3 days before the test, and avoid no sexual intercourse for 2 days before the test. So now we'll talk about the pre-analytical phase. The pre-analytical phase is the collection phase when a sample is being collected by a physician in clinic. As we see here, the physician using a speculum to visualize the squamous columnar junction to see the surface and they collect the sample from squamous columnar injection. Then they smear it immediately if they are using conventional method, or put it in the thin prep vial if they are using thin prep, or they put the head of the brush and the preservative solution if they are using sure bath. So the first issue we may face in the pre-analytical phase is insufficient patient identification, mislabel, which is highlighted here with the red color because we'll see it in each phase. And the second main issue is improper collection technique for Pap smear. So let's talk about the mislabel. The information on the patient wristband, requisition for vial or slide are not matched. Why? Because not doing timeout for patient. The timeout, it is very important where the physician and the attending nurse both say the ID number of the patient loudly. Then they ask for patient to say her name to make sure this is the correct patient with the correct requisition and the label. Also, the second reason for mislabel is print request and label slides, vials for 2 or more patients at same time. So if the sample received by the lab and there is mislabel, it will be rejected. However, if the information in the requisition form and the vial are matched, but the problem is the wrong patient, this will lead to misdiagnosis. So how could we avoid this issue? Do time out, 1 patient, 1 label, and 1 request in a clinic. 2 patient identifications at least. Do double check, and the ID of the collector and the attending nurse should be written in the requisition form and the vial. The second part in pre-analytical phase is improper collection technique for Pap smear, where the transformation zone or endocervical cells not sampled, scanty cellularity, or poor fixation for conventional method. So the transformation zone is not sampled. Why? First reason is a limited experience of the collector. And the second reason is difficult transformation zone visualization because of presence of mucus, blood, atrophic patient. So what will happen? This will affect the specimen quality, and the glandular and the squamous dysplasia may not be detected because they didn't take the sample from T-zone. How could we avoid it? If the collector using spatula and endocervical brush, the spatula must attach to the squamous columnar junction T-zone, and they rotate the spatula of 360 degree 1 time. Then they put it in the vial or smear it on the slide. That followed by using endocervical brush, which enter to the first quarter of the endocervical canal and rotate it only for 90 to 180 degree, no more than that. Or if they use broom brush, which is recommended, again, it should be attached to the squamous columnar junction area, and the tip of the brush will be in the first quarter of the endocervical canal. Then they rotate the brush 5 times clockwise, no more than 5 times. The second issue is scanty cellularity. The well-visualized squamous cells present with low quantity. Why? Again, it is the limited experience of the collector or the presence of mucus or blood. Also, using lubricant gel, especially with the thin prep, and collection brush lifted in the thin prep vial. What will happen? It will limit the adequacy of Pap smear and it will be unsatisfactory for evaluation if less than 8,000 cells in the conventional slide or less than 5,000 cells in the liquid base. How could we avoid it? Use a proper collection technique, remove excess mucus vaginal discharge before collection the sample, avoid taking Pap smear during the period, use warm water or water-soluble lubricant instead of using the gel lubricant. remove the collection brush from the thin prep vial before send it to the lab. The last issue in the pre-analytical phase is pore fixation, and here we're talking about conventional method, where the pore fixation, air drying cells causing nuclear swelling, chromatin pattern are lost, and cytoplasm become eosinophilic. Why? Because of delay sample fixation or preservation. And what will happen? It will limit the adequacy of the pap smear, and it will be unsatisfactory for evaluation if more than 75% of cells are air dry. How could we avoid it? Immediate fixation for specimen in 95 ethanol or fixative spray. This will take us to the first exercise in the first part. So we finished from pre-analytical phase. I will read the question and then could you please precipitate in the board. A scenario, today in the gynecological clinic, we have 4 booked patients for pap smear collection. We printed the requisition form and test label, as well as we labeled the collection vials for all patients before the clinic begin to be ready and to save time. So what is the technical issue that may happen? Pore fixation, mislabel, a collection brush is kept in thin prep vial, or bloody smear. So Mr. Abdelbasit, could you start?
Of course. Thank you, Mr. Abdulaziz. The exercise, the poll is in front of you now. The majority are going with option B, mislabel. We have more than 80%. Whenever you're ready to stop the poll, you endorse me, Mr. Abdulaziz.
Okay, yeah. Yes, so the correct answer, it's mislabel as the majority answer. And now we go to the next question or the exercise. What is the technical issue in this picture? It's pore fixation using lubricant gel. A collection brush is kept in the thin prep vial, or it's bloody smear. So could you please precipitate?
We do have half of them with option B and half with option C. Please, Mr. Abdulaziz, elaborate on this.
Okay, so yeah, the correct answer actually is C, keep the collection brush in thin prep vial. As we see here, for the thin prep vial, you have to check it before start processing. So this will affect the cellularity of the specimen. So could we? Now we'll move to the next part of this lecture. Sorry. Now we'll talk about analytical phase, which is sequential steps to prepare, stain, and cover slip pap smear to be ready for screening. In the pre-analytical phase, we have 2 main parts: slide preparation, and we divided the issues based on the technique: conventional smear, filtration technique, thin prep, and sedimentation technique. And the second main part in the analytical phase is the staining and covering slip, and the main issues in the staining and cover slip include overstain, understain, hematoxylin precipitate, cross-contamination, insufficient dehydration, and sufficient mounting media. So for the conventional smear, the smear was already prepared in the clinic by the physician, and it's ready for the next step or for staining. so we don't have preparation for the conventional smear in the lab. However, for filtration technique, we may face one of these issues. First one is insufficient patient identification. Again, it's mislabel, poor fixation, bloody smear, lubricant, and thick smear. So let's start by insufficient patient identification, where the information in the requisition form, vial, and slides are not matched. Why it's happening? Because of use one patient identification or mistyping. And this mistype, it happens when you label the slide. If there is a mislabel, this will lead to misdiagnosis. And how could we avoid it? Usually we must use two patients identification on the slide, and always we double check the label. The second issue is air drying artifact. As we said, it will affect the nuclear and chromatin pattern and loss cytoplasmic eosinophilic components. So why it is happening is because of the delay sample fixation, and this happens when you prepare the slide in the thin prep machine and you transfer the slide from the machine to the main container for fixation. If you delay this process, will lead to air drying artifact, and it will limit the adequacy of pap smear, and it will be unsatisfactory if more than 75% of cells are air dry. How could we avoid it? Immediate fixation for space slide in 95 ethanol. The third issue is bloody smear, where a macroscopic and microscopic examination shows bloody components. Why it's happening? Because of cervical scratch, cervical polyp, birth control pills, infection, or cervical cancer. And again, it will limit the adequacy of the pap smear, and it will be unsatisfactory if more than 75% of cells are obscured by blood. So how could we avoid this issue? We wash the smear in 10% acetic acid. The fourth issue is lubricant, where a microscopic examination of sample shows poorly stained reflect granular material. So why it's happening? Because of using lubricant gel in collection. And what will happen? It will limit the adequacy of pap smear, and it will be unsatisfactory if more than 75% of the cells are obscured by lubricant. So how could we avoid it? Use warm water or water-soluble lubricant instead of using the gel, and wash the smear with the preservative for 2 to 3 times. This may help to reduce the lubricant in the smear. Then the fifth issue in the filtration technique is thick smear, where a microscopic examination shows thick overlapping layers of cells. Why it's happening? Because of poor collection technique. As we said before, if they are using broom, it is rotated for only 5 times, no more than that. So if the collector rotated for 10 times, 15 times, this will lead to thick smear. Again, what will happen? It will limit the adequacy, and it may lead to misdetect abnormality, where the abnormal cell hid under the normal cells. How could we avoid it? Dilute specimen into vials and 2 slides. The next part is sedimentation technique in the preparation, and the issues we may face again: mislabel and drying artifact. For the mislabel, again, if there is mismatch in the patient identification or there is misplaced. As you see here, this is the rack which contain the samples and the tubes. This is the first sample here in the lift up, the second sample, third and fourth, and also the tubes. After this processing, when you transfer the tube, if by mistake you misplace and you put the tube of the first sample here in the position of the fourth sample, this is misplaced and it will lead to misdiagnosis because this sample is not related for the patient. Or when you label the slides and put them in the rack, in the short path, we start from the down or bottom left side from this mark and go up. So this is the first sample, second sample, third and fourth, and this is the fifth. So if by mistake you start from up to down, that means it is mislabeled. And again, why it's happening? Because if you use one patient identification or mistyping or misplace, and this could lead to misdiagnosis. And how could we avoid it? Use two patients identification, and always we have to double check the label. The second issue in the segmentation technique we may face is drying artifacts. Microscopic examination shows dark stain. Why it's happening? A chamber was removed and the cell surface dried before the mounting media and cover slipping. It will limit the adequacy of pap smear. And how could we avoid it? Do dehydration and clearing immediately after removing chamber. And now we'll move to the second main part in the analytical phase is the staining and cover slipping. Staining is defined as a technique used to enable better visualization of the cells and cells pattern under the microscope by using different stains. Cover slipping, a very thin piece of glass or plastic tape placed over a specimen on a glass slide that is used to examine under a microscope. So the first issue we may face in staining and cover slip is overstain and understain. The second issue, and then it's followed by hematoxylin precipitate, cross-contamination, improper dehydration and clearing, and improper mounting media. Let's start talking about overstain, where dark nuclear and cytoplasmic stain. So why it's happening? The first reason, because of the slide left too long in the stain, or the differentiation step of hematoxylin is too short, and we are talking about regressive method. If you are using regressive hematoxylin, where the smear overstain, then we remove the excess hematoxylin by acid alcohol, the differentiation step. So if it is too short, this will lead to overstain. And what will happen, as you see here in this picture, it is overstained. And how could we avoid it? Decrease the time in stain, increase the time of differentiation for hematoxylin in regressive method. The second issue is understain, which is the where pale nuclear stain and cytoplasm. Why it's happening? Not leaving a slide in stain long enough, or staining with over-oxidized stain, or over differentiation in the hematoxylin for regressive method. As we see here, this picture, it is understain, especially the cytoplasm. And how could we avoid it? Lift the stain for adequate length of time, change over-oxidized stain, decrease differentiation time in the hematoxylin. The third issue we may face in staining and cover slip is hematoxylin precipitate, a metallic sheen on the surface of the solution when exposed to air. This metallic sheen transfers or adheres to the surface of slide and cells. Why it's happening? This staining problem was produced by using hematoxylin that had oxidized. As you see here in this picture, how the hematoxylin precipitate covering the cells. And how could we avoid it? Replace or filter the hematoxylin solution. The fourth issue is cross-contamination, a slide contaminated with other cells through staining solutions. Why it's happen? A possibility of cells detaching from one slide during staining, floating away in the solution and attaching to different slide. This will lead to misdiagnosis or false diagnosis. And how could we avoid cross-contamination? Daily replace or filter staining solution, stain gyne slides separately from non-gyne and FNA, and use a blank slide as a QC slide with each staining batch. And the fifth is improper dehydration and clearing, where water under the cover slip. Why it's happen? Water contaminated xylene barrier to cover slipping. What will happen? Water on the slide. And how could we avoid it? Dehydrate the slide in 2 to 3 changes of absolute alcohol, and then clear in 2 to 3 changes of xylene to make sure you remove all the water in the slide. Then improper mounting media, where dry slide causing air bubbles and conflict artifact. Why it's happen? Because of using minimal amount of mounting media. And what will happen? It will form air bubbles and conflict artifact. And how could we avoid it? Recover slip using more mounting media. And this is the second exercise, and it's the end of the analytical phase. Again, if you can precipitate, what is the technical issue in this picture? Is it understain, improper dehydration and clearing, poor fixation, or bloody smear? Thank you for precipitating. So the majority have the correct answer, which is improper dehydration and clearing, where the water it's under the cover slip. So this next question, what is the technical issue in this picture? Overstain, poor fixation, bloody smear, or improper mounting media? So, Mr. Abdulbasit, could you go to the next question, please?
I am trying to launch it, but I'm not able to. So please write it in the comments. Thank you for participating. I'm sorry for the technical issue.
Okay, thank you. So the correct answer is improper mounting media, as we see in first pictures, conflict artifacts and the air drying artifact. And this the third question, what is the technical issue in this picture? I think we are facing a technical issue here in the presentation.
Yes, please continue to write the answer in the chat. The majority are going with option C.
Yes, thick smear. Yes, it's the correct answer. Thank you, everybody. And this is the last question in the exercise 2. What is the technical issue in this picture? Is it obscured by lubricant, poor fixation, thick smear, or improper mounting media? Yeah, we have.
The poll is back.
Yes, thank you. Thank you, Mr. Abdulbasit. So majority go with obscuring by lubricant. Yes, it's the correct answer. The lubricant obscured more than 75 of the cells. Actually, this case we repeat it, we wash it with the solution, and again it's still unsatisfactory for evaluation. Now we'll go to the last part of our presentation is post-analytical phase, where it is the screening phase. It is a systemic examination of the slide under a microscope. The main issue we may face is misdetection, or the second issue we may face is misdiagnosis. So let's start talking about misdetection, where the diagnostic material not seen. You didn't see the abnormal cell. So why this could happen? Because of scanty or hidden material, lack of concentration, and proper mounting technique. And we'll talk about each point. The scanty or hidden material, abnormal cells, changes, or infectious organisms are present with low cellularity or hiding between normal cells. And this will lead to misdetection. How could we avoid it? Careful screening, and any abnormality needs to be viewed on higher magnification. Be cautious of single cells, particularly with high grade, especially in atrophic patient, and inflammatory smear. The second reason for misdetection is lack of concentration. We're not paying a full attention to the examined slide. This could be because you're doing multitask, feel sleepy, or feeling tired and not having a break. So how could we avoid this issue? Always remember, a whole life is depending on your diagnosis, and there is a patient waiting for your result. So please make your focus in high level, and when you feel tired, take a break. And the second solution is stop screening when your focus level is low. The third reason is improper screening technique, where a random, fast, and not well overlapping field screening technique. And how could we avoid it? Use a systemic screening method and proper overlapping fields technique. As we see here, this is an example. When you start the screening, you may start from the bottom right side to the left up, or from up to down. So it is depend, but you have to use a systemic method. And the second part is overlap between the fields. When you overlap between the fields, let's see, this is the first field and this is the second. When you go to the second field, you have to see at least a quarter of the first field to make sure you don't miss the cells between the fields, because if you miss one cell, it may make difference. And again, when you move to the third field, you have to see at least a quarter of the second field. And when you go upside, again, you have to see at least the quarter of the previous field. Then we'll talk about the second part in post-analytical, and the second issue is misdiagnosis, where the diagnostic material misinterpreted. You see the diagnostic material, but you misdiagnose it. The first issue, again, is mislabel or overcall, false positive, or undercall, which is false negative. For the mislabel, if there is a mislabel, this will lead to misdiagnosis. Why it's happened? Not check the slide label before screening. So in the post-analytical phase, we are talking about the screening. Before you screen any slide, you have to double check the label on the slide label, and you can flip the slide and you see the label on the slide to make sure it is the correct slide for the patient. If there is a mistake, this will lead to misdiagnosis. And how could we avoid it? Double check the label before screening, and you could use a barcode reader to avoid mistyping issue. The second part in misdiagnosis is overcall. We're calling normal material abnormal, this is false positive, or undercall, we're calling abnormal material normal, and this false negative. So why it's happened? Because of difficult presentation, making a diagnosis too early, not considering all information for the case, or lack of knowledge, and finally, lack of experience. So let's talk about difficult presentation. The abnormal cells are present but difficult to diagnose. We usually hear the difficult presentation talking about hyperchromatic crowded groups, and it will lead to misinterpretation or misdiagnosis. And how could we avoid it? Find more material on the slide. And this is an example. If you see this picture, it shows hyperchromatic crowded group, and actually this group is endometrial cells. When you see the background, there are normal endometrial intermediate cells. However, if you see the next picture is hyperchromatic crowded groups, actually this is small cell carcinoma. Again, you have to see the whole slide, and if you see here in the background, you can see the tumor diathesis. And the third example for hyperchromatic group is this adenocarcinoma. And again, if you see the background, you will see the abnormal glandular cell. And if you screen the slide, you will find more materials to lead you to the correct diagnosis. The second reason for misdiagnosis is making a diagnosis too early. The examined smear may have more than one finding. For example, candida with the low grade with the high grade. So why it's happened misdiagnosis here? Because not continuing the screening after finding the first abnormality. Let's say if you find low grade and you stop the screening, maybe there is a high grade, especially sign 2. So you have to screen the whole slide to make sure you didn't miss any cell. Again, this will lead to misinterpretation or misdiagnosis. And how could we avoid it? Examine whole slide and each group or individual cell carefully. The third reason is not considering all information for the case. The screening slide without considering the clinical information, LMB, IUD, hysterectomy. And why it's happened? The first reason is lack of information. You don't have this information, not written to you, or you don't know, or careless. Again, this may lead to misinterpretation or misdiagnosis. And how could we avoid it? Remember always the clinical information, and this is a patient life, and your diagnosis will affect the patient. So make sure you know the all information and consider all the information before making your diagnosis. The fourth reason is lack of knowledge. The screener is not well educated or updated. Why? First reason is poor education system, or could be not following updated reporting system. Again, will lead to misdiagnosis. And how could we avoid it? Study using reference material, use local and international certificate. The site screener must be certified to screen the gynecological cytology, and always continuing education program to be updated. Then the fifth reason for misdiagnosis is lack of experience. We not have a good screening skill. Why? Maybe because of new cytoscreener in the field, or seeing a few cases. Again, this may lead to misinterpretation or misdiagnosis. And how could we avoid it? We have to do employment assessment for the new screener, at least 100 negative gynae slides must be rescreened by supervisor before allowing the cytoscreener to sign the cases, and more slides equal more experience. This is the last exercise in this lecture, and if you could you please precipitate, so I will read the question. 35-year-old pregnant women for a routine pap smear. The diagnosis of the cytoscreener was negative for intraepithelial lesion or malignancy and fungal organism morphologically consistent with Candida. So what is the technical issue here? Is misdetection, correct diagnosis, misdiagnosis, or both? So majority go with the both. So thank you, Mr. Abdel. Actually, for this picture, it is a misdetection because the cytoscreener saw the Candida, but he missed to detect the herbicide changes here in the top right side, and this is pregnant women, and this it is a critical result. Let's move to the second question. So a 32-year-old woman for routine pap smear, the diagnosis of the cytoscreener was negative for intraepithelial lesion or malignancy, and the shift in flora suggestive of bacterial vaginosis. So what is the issue? Is it misdetection, a correct diagnosis, misdiagnosis, or both? So majority go with the correct diagnosis. Okay, thank you, Mr. Abdelbasit. Actually, the correct answer is C, misdiagnosis, where the cytoscreener he or she saw this group. This is actually high grade, and he considered it as a metaplastic cells. Now we'll next go to the next question. 27-year-old women for routine pap smear. The diagnosis of the cytoscreener was atypical squamous cells of undetermined significant, ask us. So what's the technical issue? Misdetection, correct diagnosis, misdiagnosis, or both? Really, it's a little bit tricky. So majority chose B is correct diagnosis. Actually, the correct answer, it is both, where the cytoscreener missed to detect the trichomonas. It is tricky, as we see here, and it is full of trichomonas in the background, but this one, it's clear here, or another one here. And this is the effects of trichomonas, is not the effects of HPV virus. And this is the last question in our lecture. A 50-year-old woman for routine pap smear. The diagnosis was negative for intraepithelial lesion for malignancy and endometrial cells present in women over 45. So what is the issue? Is it misdiagnosis, misdetection, correct diagnosis, misdiagnosis, or both? So majority go with correct diagnosis, B. Thank you, Mr. Bassett. Yes, this is the correct diagnosis. And thank you for your precipitation in these questions. This is my reference list. And thank you so much for attending this lecture. And if you have any question, please feel free to ask.
Thank you, Mr. Abdulaziz, for this great presentation and topic. Ladies and gentlemen, if you do have questions, please raise your hand so I can ask you to unmute yourself and ask your questions, or type in your questions in the chat. Thank you for the positive feedback on the presentation.
Thank you so much.
If you do have any questions, please feel free to raise your hands or type it in the comments.
Somebody asked about the reference list.
Yes, please.
So, yes, this is my reference list. So I think there is no question, Mr. Bassett.
Okay, thank you again, Mr. Abdulaziz. Next, you may stop sharing. Thank you very much. Next, ladies and gentlemen, we do have Mrs. Noura Al-Husainan with a Master of Science. She's going to present to you about fixation and the principle of HND. Mrs. Noura is a senior histotechnologist working at Prince Mohammed bin Abdulaziz Hospital in Riyadh, Saudi Arabia. Mrs. Noura, the mic is yours. Mrs. Noura, please open the mic.
You can hear me?
Yes, we do.
Yeah.
Thank you.
Good evening, everyone. As Mr. Abdul Bassett represent me, I am Noura Al-Husainan. We are here today to gain more knowledge about fixation and the principle of H&E staining. The objective of this lecture, we're going to recognize the principle of fixation, identify the factors affecting fixation, discuss most common fixative in histopathology, recognize the principle of H&E staining, identify the different types of hematoxylin and eosin, explain the H&E staining protocol, and list the factors affecting the H&E stain. The principle of fixation. Fixation is preserving the tissue by building bonds that's stabilizing the protein within the cell wall. So it resists the upcoming changes of processing and staining by being insoluble. Fixation could be chemical, such as immersing the tissue into the fixative, or physical, as heat through denaturation. Aims of the fixative is to prevent putrefaction, which is decay by bacteria or molds. Also to prevent the autolysis, which is automatic cellular death. The another function of the fixative is to make the tissue easy to cut during the grafting by hardening it. The next function of the fixative is to maintain good relationship or perfect relationship between the cells and the extracellular substance, as the connective tissue, the fibers, and the amorphous ground substance. The last but not least is to enhancing the differences in the reflective index, which increase the visibility under the microscope. The factors affecting fixation, the most important factor I would like to begin with is time. Time is so crucial. As soon as possible, the organ removed or the tissue removed from the OR, it should be placed in the fixative to prevent the post-mortem alteration. Second, we have the pH. The pH for the formaldehyde should be around 7.2 to 7.4. Also, the third factor is temperature. Temperature, there is a direct relationship between the temperature and the rate of fixation. The increased temperature, the increased rate of fixation. This problem, we can see it more in the processor machine. The second is the ratio of the tissue to the fixative. It should be around 15 to 20 times greater. The fixative should be 15 to 20 times greater than the tissue size. Last is the formalin ventilation. The formalin or the fixative ventilation, it should be, as we know, the formalin is a slowly ventilator at approximately 1 millimeter per hour. So specimen need to be opened, sliced, and left to fix for adequate time before processing. Second, most common fixative in histopathology. The most common fixative in histopathology is 10% neutral phosphate buffered formalin. It's effective, affordable, and as we can see here, it's easy to prepare. It's just dissolve 4 grams of monobasic sodium phosphate with 6.5 grams of dibasic sodium phosphate. Dissolve it in 100 ml 37 formaldehyde and with 900 ml of distilled water. Next, the principle of H&E stain. This all about chemical affinity of the hematoxylin and eosin stain. Since the chromatin is the acidic part of the cell, the basic dye, which is the hematoxylin, is going to attract to it. On the other hand, the eosin, which is the acidic dye, will bind to the basic part of the cell and the extracellular substance such as the muscle and the RBCs. Hematoxylin is derived from Hematoxylon campiginum logwood tree. The hematin has little affinity for tissue. Therefore, adding mordant, which I will speak about it later, enables the hematin to attach to the acidic part of the tissue, such as the chromatin. Here is the mordant. As I mentioned, a substance increases the affinity of hematin to the nuclear substance in the tissue. The most used mordant is aluminum alum sulfate. In some cases, and the most of the cases, the mordant is also the oxidizer. The type of the mordant determines the final color and the type of the hematoxylin. Here we have the types of hematoxylin. First, we have the alum hematoxylin. We have Gills, Delafied, Myers, Harris, and Ehrlich's hematoxylin. As we can see here, there are the Ehrlich's and the Delafied are both naturally oxidized. The sodium iodate is used as an oxidizer in Gills and the Harris hematoxylin, which are going to mention about it. And the potassium alum is the mordant in Ehrlich's and Harris and Myers hematoxylin. Here is the types, another type of hematoxylin, which is iron hematoxylin. We have the most type here, Heinheiden and Wigret hematoxylin. They are more used in special stains. As you can see, the oxidizer and the mordant are same in Heinheiden, ferric ammonium sulfate for both of them, and the ferric chloride as an oxidizer and the mordant in Wigret hematoxylin. Eosin is the best counter stain to show variation to the hematoxylin. It can be prepared by dissolving eosin in eosin powder in 95 alcohol. The end result gonna yield in 3 shades of pink: pale pink in connective tissue, dark pink in muscles, and orange pink for the RBCs. The type of eosin, first eosin Y, which is the most widely used, and it's soluble in both alcoholic and water. Then alcoholic eosin Y, eosin B, eosinofloxacin, and picroeosin. They both serve the same purpose, and they both give the same end result. Here we going to talk about more about the staining method. We have two staining methods: the regressive staining, which is the indirect. The tissue is going to be overstained. Then we're going to use the process called differentiation, which the excess stain going to be removed until the sharp outlining of the desired part is achieved. On the other hand, we're going to talk about, there is a progressive staining, which is the direct method. The dye gonna be differentially absorbed into the tissue during a fixed staining time. Then the process is stopped, resulting in the desired degree and selectivity of staining. Here's a general staining protocol. First, we're gonna do deparaffinization, which is bringing the tissue to water. Then we're gonna stain it with hematoxylin. Then we're gonna wash it, especially if we are using then we're gonna wash it. Then we're gonna differentiate it, especially when we are using the regressive method. Then we're gonna wash it again to stop the differentiation with the regressive method. Then we're gonna do the blowing. Then we're gonna wash it and immerse it next in 95 alcohol, especially when we are using alcoholic eosin. Then we're gonna immerse it in eosin, then differentiate it and dehydrate in ascending concentration of alcohol, then cleaning with xylene and mount it in the mounting media and cover it. Differentiation, as I mentioned earlier, is the selective removal of the excess stain, usually done using alcohol with a few amount or least amount of hydrochloric acid. The idea of differentiation is to break the bond between ammonium, the tissue, and the dye. Over differentiation gonna give me pale color and remove the hematoxylin from the nuclei. The next step is blowing. Blowing is converting the red soluble color of the hematoxylin to insoluble blue-purple color. The pH, it's a pH-dependent reaction occurring in alkaline solution. Some examples of this alkaline solution is ammonia water, dilute lithium carbonate, and potassium carbonate with magnesium sulfate mixed in water, which called Scott's tap water. Here we come to the Harris hematoxylin protocol. It's more used in regressive staining, which use acidic differentiation. The disadvantage for the Harris is the lifespan for it is short. It takes about 5 minutes to fully stain the desired part, which is a long time compared to the Gill hematoxylin. As you can see here, the hematoxylin is almost 5 grams dissolved in water and alcohol. We used to use mercuric oxide, but instead of it nowadays, we used potassium iodide because it's less lethal than the mercuric oxide. The ammonium aluminum sulfate as a mordant and the acetic acid as a pH control. Next, we have the Gill hematoxylin protocol. The Gill's hematoxylin is alum hematoxylin. It's provided in 3 concentrations: the single concentration for the cytological use, and the double and the triple concentration for the histological use. The protocol for staining is 3 minutes. It's around 3 minutes. Here, the hematoxylin, you can see in the single and the double and triple, there is more concentration in double and triple. 2 grams in single, 4 grams in the double, and 6 grams in the triple. We use ammonium sulfate as a mordant and acetic acid as a pH control. Next, we're gonna talk about the factors affecting the H&E stain, the concentration of the dye. The greater the concentration of the dye, the more dye is bound to the tissue. Next, the pH of the azosin. The pH for the azosin should be around 4 to 4.2. And it's so crucial because if there is any difference or change in the pH range, that's going to change the binding ability for the dye to bind to the tissue. Third, the tissue fixation. Fixation, as I mentioned, altering the certain molecular structure inside the tissue sample. So any increasing the permeability of the tissue, it's gonna increase the permeability for staining to enter the tissue. So it's important to mention that unfixed tissue element gonna have limited binding site for the dye, or it's gonna be not staining well. Third, last but not least, the time. The time also is a crucial factor. The more time we put the slides inside the dye, the more concentration it's gonna take. So it should stick to the timing according to the protocol that we mentioned. And you're gonna know more about the factors affecting the H&E stain with my colleague Raya Al-Humaydan next with troubleshooting. These are my references. And thank you so much for your listening. I hope you get the knowledge that you intended for. Thank you so much for your listening. And I'm ready for any question. Thank you so much.
Thank you, Mrs. Noura, for this great presentation. Ladies and gentlemen, if you do have questions, please raise your hands so I can ask you to unmute and use the mic, or type in your questions in the chat, please. While waiting for questions to appear, next session will be talking about H&D troubleshooting for 10 to 15 minutes, and then we will go on a break for 15 minutes. All right, 20 more seconds if anyone is ready for any question. All right, Mrs. Noura, we have a question. Can we still be able to process the specimen when it is received half covered with fixative?
Actually, for the patient's sake, we're gonna increase the volume of the fixative and leave it for like a period of time, let's say for 1 day, then we can process it. Sometimes we face this problem in the lab. We get a little amount of fixative, so we add it more and leave it for fixed, like for 1 day, then we can process it for the next day.
Thank you, Mrs. Noura. Any more questions, ladies and gentlemen? All right, thank you, Mrs. Noura. You may end sharing your screen. Ladies and gentlemen, next I present to you Ms. Raya Al-Humaydi with a Bachelor of Science. She is a certified histotechnologist by the ASCP. She is going to talk to you about H&D troubleshooting. Ms. Raya, whenever you're ready, the mic is yours.
Assalamu alaikum warahmatullahi wabarakatuh. Hello everybody, this is me, Raya Al-Humaydi. I am a histotechnologist certified from the ASCP. And today I'm going to talk about H&D troubleshooting. And when I say troubleshooting, you must think about 3 important things, which is identify the problem, determine the cause, and find solution for the problem. And this is what troubleshoot meaning.
Ms. Raya, could you please open your mic?
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everybody. This is me, Raya Ahmadi. I am a Histotechnology certified from the CB. And today I'm going to talk about troubleshooting. And when I say troubleshooting, you must think about the most important thing, which are identify the problem, determine the cause, and find solution for the problem. And this is what troubleshoot meaning. For the object of this presentation, we will recognize the fixation effect on H&E stain and clarify the effect of iocine pH on stain, and we will talk a little bit about iocine differentiation and H&E over and under stain problem. Okay, let's start with the fixation effect on staining quality. And as you know, poor or inadequate fixation leads to poor quality on H&E stain slide. As you've seen in this picture, the nuclei showing signs of inadequate fixation, and it will appear as lack of nuclei clarity, smudgy, not crisp, and this is most likely caused by inadequate fixative, either delayed or incomplete. To avoid the problem, you should place a tissue in a fixative solution directly after removal in a volume that's up to 15 to 20 times volume of the tissue. And be sure to allow longer time to fully penetrate the tissue and fixation action take place. For formalin fixation, penetration occurs at an approximately rate of 1 millimeter per hour. It may take up to 24 to 48 hours. Formalin pigment is also one of the fixation problem, and this pigment called acid formaldehyde hematine. It may be present in a blood-containing tissue, seen both intra and extracellular, especially if the fixation is delayed or non-buffered formalin used. You can notice in these pictures, it appears as brown black crystalline deposit in and around tissue. And to prevent this pigment formation, you should use 10% neutral buffer formalin as fixative. Here we go talking about a different problem related to iocine. It might be darker or lighter, and this happens because of the effect of pH level. When it becomes above 5, the staining intensity drops. Also, when pH are below 4, the intensity becomes murky. And if you're wondering how this changes in a pH happening, I will tell you it's because of the alkaline solution used to differentiate the nuclear staining when blowing is carried over into the iocine and raises the pH. And to fix this situation, you have to maintain the pH by increasing acidity with a small amount of acetic acid. It will sharpen the iocine. And the most important thing you have to know is the required pH of iocine should be ranged from 4 to 4.5. These two pictures will represent the problem of iocine with different level of pH, where you can notice that when the pH at 4.3, how the level of a bright red coloration on the cytoplasm compared to the higher pH at 5.3, which seems a little bit pale. And this is happening because high pH, which is above the isoelectric point of the cytoplasmic protein, and this protein will not have a net positive charge and will not be attracted to the iocine. Also here you can see how the intensity is highly dependent on the pH, and at pH 5, the staining intensity drops significantly compared to the left picture, this picture on the left, where the pH level should be. And if you do a proper differentiation for iocine, you will see all three shades of iocine with clearly with different type of the tissue, where the cytoplasm generally stains pink, collagen stains orange, while other tissue since various shades of pink. And the thing I have mentioned is the best differentiation occur at 70% alcohol. And I think this two picture will shows how important of differentiation of iocine will affect the staining quality. In the next two slides, I'm going to discuss with you guys the problems happen with hematoxylin, why it's sometimes going to be over or understained, and how to fix similar situation. And as you've shown in this picture, how much dark or overstained hematoxylin affect the chromatin pattern. And this is caused by three common factors, which are strong hematoxylin, staining time is too long, or inadequate differentiation of hematoxylin. And for the solution, you must change a strong hematoxylin with weaker formulation or adjust the protocol to decrease the time of hematoxylin. Also, you can increase time in differentiation solution. It may be help to reduce the intensity. Let's take a look on this section where you can notice the hematoxylin on this slide looks so pale. And there are many factors may cause this problem. The first and most common cause is incomplete deparaffinization, or sometimes hematoxylin itself is over or expired or diluted by carryover. Also, the pH can cause the problem if it was incorrect, or maybe the differentiation step take a little bit longer, or staining time in hematoxylin is too short. Also, the fixation could be a problem if was improper way. And as you know, guys, fixation is always affecting on almost everything. And sometimes it may be a cutting problem and the section too thin at cutting. And here we have a list of solutions for each cause. And for example, you may increase oven time or temperature or changes of xylene for proper and ensure complete dewax. Also, you can change hematoxylin solution and store hematoxylin in a dark container to prevent over-oxidization. Also, you can check and adjust the pH and decrease differentiation time and decrease the acid concentration of the differentiation. Also, you can increase the time in hematoxylin solution if the shortening time is a reason. Here's one of the common problem we may face is a contaminant slide with water, whatever the source. And it will affect the clarity of the section where it seems hazy appearance or cloudy. And to fix the problem, basically you have to change the solution periodically to avoid or at least minimize the contamination that may carry over throughout solution. Also, you can use a minimum 3 changes of alcohol at the end of staining to ensure complete water removal. Also, you can increase the time per each changes to avoid this problem. Finally, here we have the problem of the variation in staining intensity throughout the section, and this is one of the most common problems happened. And this might be a result of cutting problem or solution maybe not enough to cover entire section, or maybe differentiation or blowing used, the volume is higher than water rinse. And for a fixed solution and for a solution for this variation, simply just recut a good section or ensure the all solution in a sufficient volume to cover whole section. Also be sure the water level is higher than acid, is higher than acid, alcohol, or blow-in solution level. This is my end of my presentation. And this is the sources I used to prepare presentation material. I hope you guys enjoy listening. And thank you for attending here today. And if you have any question, please don't hesitate to ask.
Thank you, Ms. Ria. Ladies and gentlemen, if you do have questions, please raise your hands or type in your questions in the chat. Thirty more seconds to receive questions in the chat or by raising your hands. Ms. Raya, we do have a question. What is the proper way to fix cell blocks?
We can use 95% alcohol, or if you want a rapid fixation, you can use absolute alcohol. That's what we used in our lab.
All right. In our facility, if we want to fix cell blocks, especially if we're going to run immunohistochemistry, we're going to fix the cell block in formalin before being processed in the machine that actually has formalin. And please make sure to validate the immunohistochemistry that you are using, because the cell block is fixed with alcohol prior to the formalin. Mr. We do have another question. What is the best hematoxylin used for staining, gels 1 or gels 2?
I think it depends on the protocol you used in your laboratory.
Right, correct, Mr. Rafat. It depends whether you're using it for cytology or histology. As Mrs. Noura spoke in her lecture, she said that a double has 4 grams per liter of hematoxylin, while gel 1 has 2 grams. Mostly gel 1 is used for cytological staining. You may use 2 and 3 in your histology specimen, depending on the protocol that you use. Any more questions? Right, 10 more seconds for the questions. All right, Ms. Raya, we do have a question, but before I ask the question, this question has been asked by Mr. Jumar Custodio. Mr. Jumar, thank you for attending this session. Mr. Jumar is the president of the Philippine Society of Histotechnology. Thank you for inviting your members to attend this session. Ms. Raya, the question is, do you stain control slides in every batch?
It should be. How you guarantee your quality of the staining? The control should be processed in every batch.
All right, I do want to say something in this regard. If you're using an instrument to stain your slides, before you run patient sample, it is recommended that you run a control by itself to check for everything before placing in the actual patient slides. But in our facility, we do not run a control by itself with the patient sample, because the patient sample serve as a control by themselves, and the control that run are actually prior to them. And once it's approved, everything theoretically should be okay, because it's a machine and it's only moving arms. Mr. Jamar, I am thrilled to hear about your experience in the Philippines. So I'm going to ask you to unmute and tell us about the experience in the Philippines. Do you actually stain control slides in every batch?
Hello, good day to everyone.
Good
Yeah,
evening.
thank you for that. So here in the Philippines, actually, it depends on the laboratory, but on other laboratories, we run control slides, especially appendix as a control, because usually the appendix tissue has most of the cellular elements that are were being assessed for in terms of nuclear and cytoplasmic intensity of the stain. So yeah, we do run controls in our laboratory specifically. We run controls in every batch to ensure that every batch of staining is on par with every run that we have. So I'm not sure with the other laboratories or your laboratories.
Great, thank you, Mr. Jomar. I think it is similar in Saudi Arabia. It depends on the laboratories. Like Ms. Raya said, in their laboratory, they do run control with each batch, while in ours, we don't. We run it before the patient sample. Thank you again for your participation. Any more questions? All right, Ms. Raya, there is a question here. It says, we noticed that CAP evaluate H&D staining for biopsy different than surgical. Is there a special protocol for both?
Sorry, the question is not clear. Can you repeat it?
Okay, so the question is, do you have different staining protocols for surgical biopsies and the let's say endoscopic biopsies or smaller biopsies, surgical
staining,
specimen
you
and
mean?
biopsies? Yeah.
No, it's the same. Only in process, it's a different program, but in staining, it's the same.
Right.
Did anyone do a different program for staining if the biopsy was a big biopsy or a small biopsy? I don't think.
Yes, thank you, Ms. Rai. This is a good question. If anyone uses, let's say, a different staining protocol for biopsies other than the surgical specimen, please write in the chat. We would love to hear your experience with that. For the CAP, I think the evaluator from the CAP is actually going to be a pathologist. So, and it depends if, let's say, a pathologist determines that biopsies should be run, let's say, with more hematoxylin time, while as where let's say the surgical specimen, let's say 3 minutes, 4 minutes, but he needs increase more minute in the biopsies. It's going to be solely on him and how to defend his let's say choice. But yes, please, if you do actually have different protocol, please share with us. Right, so we have a comment from the person who asked the question. Says, but B had good results for surgical, but not the same for biopsies. Thank you for your comment. If any more questions you have, please feel free to raise your hands in the following 10 minutes or type it in the chat before we go to a break. All right, thank you, Ms. Raya, for your presentation and for your time. Ladies and gentlemen, we will take a break for 15 minutes and then we will be back. Again, it's going to be a break time for 15 minutes. We'll be back soon. Thank you. All right, ladies and gentlemen, thank you. Welcome back. I will be introducing to you the following session. I will be talking about international standards and histology laboratories. This is Abdul Basit Andijani, a senior specialist in cytopathology, chairman of the Saudi Society of Cytotechnology and Histotechnology. The objectives to recognize pre-analytical, analytical, and post-analytical phases in histology labs, and discuss College of American Pathologists standards in anatomical pathology. All right, so let me go back to the College of American Pathologists standards. Now, many laboratories outside the USA seek accreditation by the CAP, and they must follow their standards and their laboratory. I will be covering the histology part, known as anatomical pathology. We do have a project in the Saudi Society of Cytotechnology and Histotechnology where we are going to unify the policies and if we're lucky, the procedure as well as in histology and cytology labs, especially for those laboratories who don't have accreditation or they don't have access to those standards. Basically, we're collecting the national and international standards in Saudi Arabia and internationally from the CAP and other areas. And we're going to put them in our own words in 3 phases: the pre-analytical phase, analytical phase, and post-analytical phase. And we're talking about the process management. To do that, we had to define first what are those 3 phases. So we came to a conclusion that a pre-analytical phase are all the procedures preceding grossing. Let's say your test requisitions, specimen receiving, fixation, anything before the grossing. Analytical phase starts with the grossing, processing, cutting, staining, and applying cover slips. There is a specimen accessioning and the computer services. It overlaps between those 2, but there are no standards in accessioning those. Most laboratories will have to follow their own LIS protocols. And what I mean by LIS is the laboratory information system. The 3rd phase is going to be the post-analytical phase, and it's going to be about reporting, documents, and slide retention. So in the pre-analytical phase standards, the following standards requests for tests bear sufficient information, including as applicable, but not limited to 2 patient identifiers: patient full name, complete name. And national standards in Saudi Arabia ask the laboratories to have 3 patient name, the first, middle, and last name. Unlike the outside where they use when I mean outside Saudi Arabia, they use first and last, and then the initial of the second. And in addition to the name, a unique identification number like the medical record number. The patient age or date of birth, sex, and patient education has to be written also on the request. Name and address, if different than the receiving laboratory, of the physician. Legally authorized person ordering the test, or name and address of the laboratory referring to the specimen. And also what is the required test, the date of specimen collection, and if appropriate, time of collection. Breast cancer that needs HER2 immunohistochemistry or in situ hybridization or ER must document the time of removal on time in formalin. Let's say that you received a mastectomy or a lumpectomy for a frozen section. Please document the time that you received and the time you start to put in formalin, because it is crucial for the antigenicity of those tests. And the last thing are the additional clinical informations like the specimen source and the clinical history. A specimen container is okay. I have a question from Dr. Amna Mulana that says the slide is moving. I have the slide moving. Can we confirm from other participants that you can actually see the slides moving? I am on the slide pre-analytical phase standards.
It's in the introduction slide, so it is the first slide.
Okay, so you guys are still on the first slide. Okay. No problem. Sorry for the technical issue. I will share again with you shortly. Right, is the presentation appearing to you now on the pre-analytical phase standards? Okay, is the slide moving now? Yes, thank you. All right, so we'll go back to our slide. The pre-analytical phase standards, and again, sorry for the technical issue, the specimen container is immediately labeled after sample collection. Two patient identifier, patient name, middle and last name, and patient unique identification number has to be on the container, date and time of specimen collection, Saudi standard from Sibahi. Identification of the person collecting the specimen is a Saudi standard from Sibahi. And what I mean by Sibahi is the Saudi Central Board for Accreditation of Healthcare Institutions. They do require date and time of collection plus the physician ID or the nurse ID who placed or who collected the specimen. That must be written on the request and the container. All right, next, we're going to talk about specimen receiving and inspection. So the date and time of a specimen receipt. This is primarily done by the computer or the ELIAS system. Check for proper packaging, check for quality and quantity of a specimen, check for adequacy of a specimen labeling, check for request completion of the standards we mentioned earlier, check for label request discrepancies, and if there is any suboptimal specimen, it has to be clearly highlighted in the reported result. And then the final decision, whether you accept or reject. Please do record rejected cases and notify the physician who ordered the test that the specimen is rejected, and await his further instructions if he deemed it is necessary. Then in this case, we're going to treat it as a suboptimal specimen, in which case we're going to write exactly what happens and the dialogue with the physician and his ID and the date and time on the final report of the patient. The analytical phase standards. All surgical pathology reports include gross descriptions, information essential for diagnosis and patient care, and essential processing information. Descriptions must include information regarding type, number, dimensions, and weight of a specimen, measurement, and extent of gross lesion as applicable. Processing information must include a summary of block slide designation. Block A is tip, block B is, etc. Type of a specimen fixation and processing. For example, formalin fixed, paraffin embedded section, or air dried imprints, or if any other fixative other than the formalin is used, or if you're using let's say a wax different than paraffin, resin, or something else has to be clearly stated. Cold ischemia time and length of time and fixative as applicable, as mentioned earlier. Gross specimens are retained at least 2 weeks after the final reports are signed, and results are reported to the referring physician. This is from the CAP itself, that please maintain your gross specimen until 2 weeks after the sign out of the patient. They also require measuring the pH of the 10% neutral buffer formalin for each batch. Positive and negative control with each special stain and immunohistochemistry, and of course internal negative elements are accepted, and daily quality control documentation. So because we are mainly dealing with the analytical phase in histology, so I gathered all the almost all the standards that are required in the analytical phase and put them on this table. For example, this starts as a daily quality log, and then you write the date. On the left top, we're going to talk about the quality of crossed specimen. So basically, the technologist or the person who doing the embedding and the cutting will be evaluating the person who made the crossing. If they are all okay or all okay except the following cases where you write your specimen number and then you tick whatever was the problem, let's say not fixed or underfixed, or it was thick or calcified or it has stables. You can put your own reasons in there and then what is the corrective action taken, and you can duplicate those 3 rows as much as you want. Second, it's going to be the quality of the routine tissue processor, if it is okay or it was defective and what was the reason for the defect. Let's just say the machine stopped in the middle run on xylene or an alcohol, and what was the corrective actions taken. The quality of microwave tissue processor, if you are if you have a microwave tissue processor, the quality of auto embedding machine or manual embedding machine, is it okay, was it defective? The daily QC of the diff quick, of course, and the most important thing is the quality of the histologic preparation, where the supervisors or the pathologists can provide feedback on the preparations such as embedding, cutting, staining, cover slipping, if they're all okay, or all okay except the following cases where you write the histology number. What was the fault? Let's just say wrong orientation or a chatter in the cutting, or understained or overstained, or if there is cross contamination. Many variables out there. And what was your corrective action? The quality of frozen sections, if any. The daily QC of H&D and standing machine. Of course, if you have a standing machine and you run, like Mr. Jumar said, an appendix before the run, you are checking actually both the standing machine and the hematoxylin and eosin itself. And then we have the daily QC of pap stain, staining machine, and thin prep machine. Say you have a thin prep machine that you are running a cytology. So you're going to process one old specimen, 3 weeks, let's say 3 weeks old, that been released already. You are going to check for the thin prep machine by itself if it is functional, and then you are going to stain it in the machine to check the machine if it is working properly, and of course the pap stain if there is, let's say, any changes required in the staining solution. And finally, checked by your name, the position as a supervisor, and the Saudi Sibahi standard require that all activity must be checked by a pathologist. So we have a row there for the head of the department, which is going to be the head of the department. You're welcome to take a screenshot of this table. If you need a soft copy, please email us, contact us as shown in the registration email that you have. Next, we're talking about the post-analytical phases standards. Basically, they're asking to keep the accession log records for 2 years, the wet tissue or the stock bottle, let's say the gross specimen, you took a representative from an appendix, then please keep that 2 weeks after final report. Some laboratories have seen that they keep the larger tissues that have malignancy for long period. Actually keeping the tissue in a formalin alter the antigenicity of the immunohistochemistry. So please read about that and think about, is it okay to keep this for a month or 2 or 3 or even for 8 months, as I've seen myself. Paraffin block, including cell blocks, has to be stored for 10 years. Immunohistochemistry batch control slides have to be maintained for 2 years. And then glass slides, whether histology, cytology, any glass slides will have to be stored for 10 years. And then the surgical pathology reports, 10 years. And of course, if you are using an LIS, everything will be stored safely in your institution. Thank you. for your time in this presentation. If you have any questions, please raise your hand so I am able to unmute you, or please ask your questions in the chat. Please take the time. If you have any questions regarding the international standards, I understand it is a vast topic that needs more time actually in elaborating those standards and how to accomplish and or to maintain or to adhere to comply to those standards. The only time we're given was 10 to 15 minutes. Definitely, we're going to talk about these standards more and more. Thank you guys for the positive feedbacks. All right, if you don't have questions in the 10 coming seconds, I will introduce our next speaker. Thank you very much. So our next speaker is Dr. Osama Basalim, Bachelor of Science, Master of Science, and a PhD, Assistant Professor of Cellular and Histotechnology, Faculty of Applied Medical Sciences at King Abdulaziz University. Dr. Osama is going to talk about gastrointestinal tract biopsies. The mic is yours, Dr. Osama.
Thank you, Mr. Abdul Basit. Hello, everyone, and welcome to this session. My name is Osama Basalim, and I'm glad to introduce a talk about the gastrointestinal tract biopsies. For the sake of this presentation, I will just share some information about the small intestine, because the reason for choosing the small intestine, because macroscopically or anatomically, when we examine the small intestine, it looks exactly the same, where under the microscope, it looks very different. So in today's presentation, by the end of this lecture, I hope you will be able to identify parts of the small intestine, explain the histological differences between each part of the small intestine, as well as compare the functions of small intestine and relate them to the anatomical segment. So as you all know, the small intestine is located in the intraperitoneal cavity, and it is highly convoluted and extends from the pyloric sphincter of the stomach all the way to the ileocecal valve of the large intestine. And there are three anatomical segments of the small intestine. We have the duodenum, which is right after the stomach, and we have the jejunum, which is the middle part or the bulk part of the small intestine. And finally, we have the ileum, which is the end part which connects to the large intestine. There are four layers, and these layers are exactly the same, starting from the esophagus all the way to the colon. So all the digestive tract share the same mucosa, and the submucosa and the muscularis propria and the adventitia. Well, I will not go to details for each of them, but remember that all the gastrointestinal tract share these layers. So the first segment is the duodenum. So when we examine the duodenum, it has this structure, which is called villi. So each villi here, we have to relate it to the function of the villi. So we have all these wrinkles or all these gaps in here because the food is coming partly digested by the stomach, and it needs further digestion and it needs further absorption. So the villi here and all these areas in between is to increase the digesting of the food and the absorption and help in absorbing the food. So in the villi or the epithelium in here in each villi, if we take a closer look here, This is how it looks. And in the villi, we will see two types of cell. We have the enterocytes, which is the absorptive cells, and it secretes enzymes for digestion and absorption. And we have the goblet cells, which appears here as these transparent cells, and it is a mucus-producing cell. So the first difference between the two is the amount of goblet cells, which are little, and secondly, the large villi, which look like leaf-shaped kind of projection. And we also have cryptophleboconch that is in between the villi. So when we look at, for example, this villi, if we take a closer look here, so at the base here, we will have these crypts. So in these crypts, we have the stem cell, which give rise to the two types of cell that I just mentioned, the enterocyte and the goblet cell. Then we have something very characteristic for the duodenum, which is the burner glands in the submucosal area. So these glands, as the food is coming from the stomach, it is highly acidic. These burner glands neutralize the chyme, and it helps by secreting alkaline mucus to neutralize the pH of the chyme or the food that is just coming out of the stomach. Another example or another structure that is present in all the duodenum, jejunum, and the ileum is the Paneth cell. So these cells, as you can see, they look eosinophilic because it contains antibacterial enzymes. So if we move to the next part, the jejunum, this is the bulk area of the small intestine. So probably if you have any biopsies from the small intestine, probably, but not always, it will be jejunum. So the jejunum, as we just mentioned, it also have this villi structure, and it has the crypt at the bottom here. But if we look at the function, before we look at the structure, the food now is digested, so we do not need the burner glands. So in the submucosa, we don't need the burner glands because the food is already neutralized by the duodenum. We also do not have Pierce patches, which makes sense because the food here was already had a lot of secretions and from the stomach and from the duodenum. So we do not need Pierce patches, which is the immune part where all the cells look for any abnormal structures or abnormal microbes, and it takes them to the Pierce patches for the immune response to begin. And of course, as we move downward from the duodenum, we will have goblet cells. As you saw before, the amount of goblet cells are not that many in the duodenum. But if we look at the jejunum, we have a bit more compared to the duodenum, and the shape of each of these villi look shorter, and it looks like finger-like projection because we do not need a lot of digestion in this area. So the goal of this jejunum is to help in absorbing the food and pass it down to the next part. Finally, the next part of the small intestine is the ileum. So the ileum, if we think first off about the function of the ileum, so all the food has been already processed, digested, and then we need part of absorption in the ileum. So we will have a lot more goblet cells in this part of the small intestine, and we will have Pierce patches because now all the food has been digested, all the food has been neutralized. But if we have any parasites or any bacteria that was not dissolved or not neutralized by the previous two sections, we will take it, the immune system will take it down to the Pierce patches and then start introducing those antigens. And we're mainly talking about not the bacterial, but we mainly talk about parasites, because this is where the ileum comes in handy, and it starts with the Pierce patches in the ileum and all the way to the large intestine. Of course, we will have fewer placa circularis or the valve of Kircher. So this valve or the muscle, actually what it does is help pushing down the food. And as we started in the esophagus with the valve, so when we start there, all the muscles need to push down the food, because you can think about the time that takes from swallowing the food all the way till it's reached the stomach. So in that time, we need a bit faster movement. But when we are in the ileum, those muscles should be reduced, and that is what's happening. And the reason for that is the anatomical function. And the function of that ileum is to push the food now, because we've got all the food, we've got all the nutrients, we've got all the vitamins, we've got everything that we need. So the movement of the food at that part is taking a bit slower, in case once it's exit the ileum to the colon, the only part there will be absorbing any fluids if it's necessary. Again, they share the same structure as the duodenum and jejunum. It has the same villi, but if we compare the villi here, they are shorter. They are finger-like projection, just like the jejunum, but they are shorter and less in number. And that's what makes the ileum different from the duodenum and the jejunum. Of course, when we look at the goblet cells, as I mentioned, we need a lot of goblet cells because we need more mucus. So because a lower amount of muscles in the ileum. And the main function, as I mentioned, is just to mucoid all the parts and push down the rest of the food to the large intestine. So to sum up all the differences between the duodenum, jejunum, ileum, before we talked about that, we need to keep in mind the function of each part of the small intestine. The duodenum, we need a lot of digestion and a lot of help to digest the food and break down all the food particles. So we will have the enterocytes and the burner glands to neutralize the food and get all the benefits from the food in this part. When we move down to the jejunum, all the food, as I mentioned, has been digested. So the main differences is just we will have the finger-like projection, and the finger-like projection will be lower in size compared to the lot and leaf and large shape villi seen in the duodenum. Of course, we will have no burner glands because, as I mentioned, the food has been neutralized. So the food will pass safely to the next part, which is the ileum. So here, as I mentioned, we will have no burner glands or Pierce patches because everything has been neutralized. Here in the ileum, the projections are lower in number, of course, and the size of those projections or the villi will be shorter, and we will have no burner glands, but we will have abundance of Pierce patches. And as I mentioned, this is a protective mechanism for the immune system, and that is how the body can fight parasites or any microbes seen in the digestive tract. So thank you for listening. And if you have any questions, I'm happy to receive them. Thank you very much.
Thank you very much, Dr. Osama, for this great presentation. Ladies and gentlemen, if you do have questions, please raise your hand so I am able to unmute you, or please ask it directly in the chat. Thank you for the positive feedback. And of course, Dr. Osama will be presenting more presentations on histology under the microscope in the upcoming events that we will announce later on. So thank you, Dr. Osama, for your time and your effort. We appreciate that.
My pleasure. Thank you very much.
Ladies and gentlemen, if you do still have questions, please. The mic is yours. Okay, so our next speaker is Mr. Ahmed Al-Awaji with a Master of Science in Clinical Laboratory Sciences Mr. Ahmed is an IFBA certified professional in biorisk management. He's also OSHA Academy certified professional in occupational safety and health with over than 29 years experience as a certified medical senior microbiology technologist. He is the laboratory biosafety officer at KAMC CR Laboratories, a system of top 10 over the Middle East. He's also known as Awaji, the lab biosafety now, the lab biosafety man. Mr. Ahmed Awaji, the mic is yours whenever you're ready.
Thank you very much, Chairman. عليكم ورحمة الله. الحمد لله الذي بنعمته تتم الصالحات، والصلاة والسلام على النبي المصطفى وعلى آله وصحبه أجمعين. Do you hear me?
Yes, we do. Thank you.
Today we will talk about the basic concept of biorisk management system. By the end of this session, we'll be able to practice or identify the CNN workshop 15793 standard. Actually, this standard is a voluntary standard which developed through the international collaboration to outline a set of requirements that established a biorisk management system for handling storage of biological agents, and also improve the understanding and management of the risk associated with accidental and deliberate misuse of biological agents. This is represented actually the biosecurity. Also be able to identify the component of biorisk management system. We mean the component is the risk assessment, risk mitigation, and performance assessment. And for both the program biosafety and biosecurity, because the risk, as you know, associated with biological material in laboratory could be biosafety, the issue, or biosecurity, or both of them. In the end, we'll be able to differentiate among the bio-risk and biosafety and biosecurity. Differentiate also when we call it the harm, we call it as a risk or considered as a hazard.
Mr. Ahmed, the mic is away from your mouth. Could you please maintain the mic level, please?
Is it okay now?
Yes, now it is. Thank you very much.
Okay. By the end, we will talk, inshallah, about the basic concept of the risk assessment, inshallah, in details, selecting the appropriate risk mitigation measures, and selecting the primary containment device. And we come to the most important part, or how to identify the factor requirement for the continual improvement. Be able to use the mic. Is it okay now?
Yes, okay. Thank you very much.
Okay. Before to start to talk about the biorisk management system, I prefer to give the short outline or the outline of the history of the biosafety management. That started at 2011. We call it the year of biosafety, at the 14th IBSA annual conference, with European CDC, European CDC, what we have opportunity to bring together the laboratory and biosafety expert to discuss the development of effective pan-European biosafety network. What's happened? There's something wrong.
We
Mr.
see
Chair?
the slide outline of biosafety management. You can click on the slide itself and then press next. Yes.
Okay. At the same year, declaration of the International Federation of Biosafety Association on advancing global biosafety and biosecurity through ensuring the quality and professionality of biorisk management through different projects and programs. Certification program is one of them. The International Federation, actually, we can have here to talk, a brief note, collection about the International Federation of Biosafety Association, IFBA, is not a profit, non-governmental organization of regional national biosafety association from all areas of the world. They are a global community of certified biorisk management professionals who have a common interest in safe, secure, responsible work with biological material. My voice is clear, isn't it?
Yes, clear. Please continue.
Okay.
Thank you.
Scope of IFBA, actually how to minimize or to reduce the bioterrorism, disease outbreak, lack of awareness, unintended research, and so on, deliberate the misuse through many programs, as you see in the core of this slide, professional certification, biorisk management, best practice. But actually, this task cannot be managed or controlled by a few associations or countries. Addressing this issue required a global commitment and good interaction with multiple stakeholders at the international, regional, and local level. And the most important, with like-minded professional association that provide professional development opportunities for biorisk management models. The long-term goals for the association, promoting the biosafety education, particularly of the younger generation, involving curriculum development within a common framework and a common methodology for evaluation. Supporting appropriate and practical legislative framework developments, developing strategy to obtain funding for applied biosafety and biosecurity research program. Short-term goals, raising awareness from the political and public perspective, and encouraging collaboration among human and animal health community, developing sustainable biosafety association, and mapping gaps and needs, providing advice to the competent national authorities and service for the improvement of efficient waste management, and that it should be through the disseminating a knowledge of appropriate system, tools, and technology for public and veterinary health environments. We come to the last point, promoting human and laboratory capacity building with proper identification of gaps and need, and that it should be through using the best available concept, principle, and practice. Biorisk management definition, we can say biorisk management, it could be a single management system, or as usual, it is a part of management system used to establish the policies, objectives, and describe the appropriate process to achieve those objectives of biorisk management system. By other words, I can simplify this statement. It means effective management of risk in a laboratory due to the due to the infectious agent and toxin handling. In order to control safety, security, biocontainment of those risks associated with handling and or storage and disposal of biological agent and toxin in laboratory facility. Biosecurity actually have two divisions. One of them concern about provide preventive measures designed to reduce the risk of intentional removal or misuse of the biological agent. It's mean, in the other word, how to protect the biological agents from the human. We call it this biosecurity. And the other side, other set of preventive measures designed to reduce the risk of accidental exposure to release of release of biological agent. We call it a biosafety, which means protected human or the health worker and their communities from the biological agent. Actually, the laboratory biosafety and biosecurity treated this different risk or mitigate the different risk, but they are sharing in one goals that how to protect the valuable biological material, VBM, and valuable laboratory material safely, securely in the workplace where they are stored and used. Overlap of biosafety and biosecurity. As I mentioned, on the biosafety side, to prevent unintentional exposure to pathogens and toxins or their intentional release, we have to implement required technologies and good practice as a technical facility, directed airflow practice and procedure, good personal protective equipment, proper practice as hand hygiene, cleaning the spill, and so on. And the others, other side, biosecurity, in order to prevent what? The unauthorized access, loss, theft, misuse, diversion, or intentional release of valuable biological material within the laboratory, we need actually to give a good protection, control, and accountability. This is the most important part, accountability. This is as we can mention as door with lock, password, biometric means as a fingerprint, camera, informational security, magnetic switch on door, alarm, and so on. There is a sharing practice between the biosafety and biosecurity, because the biosafety and biosecurity, it's two programs. It's not totally separated programs. It's depending on each other, like access control, personal management, personal reliability, inventory of biological hazard, proper decontamination, and sample delivered. It could be sharing between both biosafety and biosecurity. I can also summarize all that talk for biosafety, containment, good microbiology, and safety equipment, waste management. And the other side, biosecurity protection, we call it protection, control, and accountability. We come to the next slide. I need to, here I have some terms and definition to simplify understanding the next slide. Biohazard definition, potential source of harm caused by biological material. If we use the suffix of this word, hazard, we can identify it as a potential source of harm caused by non-biological material. When we have to start to call the harm a risk, when there is a combination of likelihood of incident and the severity of the harm consequences if that incident were to occur. Actually, probability of incident occurring in the lab, in the laboratory work, we call it likelihood, and the outcome of incident defined as the consequences. The consequences, it can be a variety or have a wide range, started from the physical injury up to environmental contamination or asymptomatic carriage of biological agent. Risk classification, it have to be based or classified the risk. It have to be based on route of exposure as inhalation, ingestion, contact, percutaneous, agents and type of pathogenicity, infectious dose. As you know, the biological agent have been classified into 4 hazard groups based on their pathogenicity, infectious dose, mode of transmission, host range, effective preventive measures, and availability of effective treatment. And we have a live example, COVID-19. It started as a high classified, and once they have the vaccine, started to minimize the classification. Also, procedure, the third factor, it have to be considered the procedure, laboratory procedure, work, structure, equipment, facility, which I mean the facility, the biocontainment, the biosafety level, and the type of control used. Personal health status, qualification, training, human factors, it's very highly important as the example, the behaviors, reliability, and errors. From the previous slide, we can easily understand the purpose of the biosafety, which mean to reduce or eliminate the exposure of laboratory workers and their community to potential hazard agent, and in order to containment the potential harmful biological agent as the main objective, biosafety objectives. And this objective, it's not achievable at all without appropriate maintained or handled the biological sample. At the same time, have to be strict adherence to standard of laboratory practice and techniques. From the purpose, when we understand the purpose and the main objective, it's easily to draw the framework of the biosafety. It's depend on the risk assessment, which mean the process for identify the hazard, evaluating the risk associated with biological agent toxin. At the time, we have to consider adequacy of an existing control and deciding whether accepted or not accepted risk. Mainly, we do that to protect the laboratory health workers and their environmentals and the surrounding community, and at the same time protected the patient beyond prevent the specimen contamination in the laboratory. The result or the outcome of that, the result, the accuracy of the result, it's come from the risk assessment directly affected the containment measures. Containment measures, it could be equipment, it could be action that are put in place to reduce or eliminate the risk associated with biological agent and toxin. I come to this slide. If you have any quick questions related to the previous slide before go to the next stage.
Ladies and gentlemen, if you do have questions, please write it down in the chat or please raise your hand so I'm able to unmute your mic. Thank you. Mr. Ahmed, we're going to give 10 seconds for the questions to arrive. After 10 seconds, you may continue, please. Thank you.
Okay.
Please continue.
Okay, please. The biorisk management, or requirement of the biorisk management, there is two important aspects. It could be, or it have to be available for started the biorisk management. The first one, we call it general requirement. General requirement, it's represented the appropriate policy management aspect that gave priority. Sorry for that. Appropriate policy and management aspect that gave the priority for protecting employee and their community environment from accidental or unauthorized intentional release of biological material from the facility and appropriate biocontainment system. The second requirement, we call it the continual improvement of biorisk management system. This is the only way to develop and achieve the development in our system. That it should be through the use the policy, the established policies, objective self-audit programs, self-audit result analysis of data, risk assessment, and corrective action. And please don't forget the management review. It's the most important part in this step. Biorisk management modules, we can, as you see, it's from top down pyramid view, started by understanding the organization and its contents. We mean this, the purpose of the organization and its objective and boundaries of its work shall be clearly defined and communicated through the organization. And we should also understanding the needs of the interested parties and their requirements that are relevant to the biorisk management system, to simplify, like Saudi CDC, MOH, and so on. To know the scope of biorisk management have to be determined the boundaries and the applicability of the biorisk management system of the organization biorisk management system. We come to the most important part, leadership. وما أدراك ما leadership. The leadership should be or started by qualified leadership to take an ultimate responsibility for the organization biorisk management system. As you know, any management system approach should be built on continual process to meet its goal, started by planning, operation issues, performance measurements, and started and ended by reviewing the performance measures in order to improve or develop and implemented the developments. The biorisk management system, it's very highly important, and it's necessary to assist the organization to fulfill its legal requirement and other requirements, and also enable the organization to effectively identify, monitor, control the laboratory biosafety and biosecurity aspects of the organization activities. To establishing and implementing the biorisk management system, we have to know what's the key factor required to start our programs. The first factor, or the first part, it's commitment by the top management. Commitment, we mean iltizam by the top management, or ta'ahud by the top management, to provide adequate resources, prioritize and communicate biosafety and biosecurity policy, established performance expectation, integrate the biorisk management throughout the organization, determine the causes of incident and nonconformity, prevent reoccurrence. So, identify opportunities for improvement and prevention. The second factors focus on continual improvement, to make the continual improvement priority for every individual in the organization, use periodic assessment against risk criteria established by the organization, continually improve the effectiveness and efficiency of the process, take corrective action for unsafe and secure practice to promote preventive activities, provide the qualified workers, and at the same time, we have to provide appropriate education training to support the biorisk management. Established measures and goal for improvement. This is important, but the highly important, we have all the time recognize the improvement. This is very highly important to achieve to the next stage. Three components of biorisk management system. I have an example to simplify the whole things. The biorisk management system, it's look like as a kangaroo, have two hands for fighting boxing. We here represented the biosafety and biosecurity programs, and two legs and strong tails represented the assessment and mitigation and performance measures. How to how to implement the AMB into the biorisk management system. First of all, assessment, we have to hazard identification. Hazard identification, we have to look around at the workplace and think about what may cause harm. Type of biological agent will be handled, by a type of pathogenicity, procedure will be used, type of equipment, and so on. What is the overall? Also, we have to consider the overall, the initial risk of the activities. Initial risk, I mean the risk without any control measures, and what is the acceptable and non-acceptable or unacceptable risk. And we have to look back, keep in your mind to look back for incident, accident, and non-conformity record to identify the root causes. Keep in your mind also the most important part. We have colleagues, we call them the vulnerable workers, which need special particular requirement. It have to be considered when we start to do identification the hazard. After we identify the hazard, we have to do the assess the risk through decide how might be harmed and how. What you are already doing to control the risk, what's the further action I need to take to control the risk, and who needs to carry out the action. This is the most important part. Once we finish from the assessment, we go to mitigation, or we call it the develop risk control strategy. Ask ourselves by following the strategy plan for risk reduction. The first one, can I get rid of the hazard altogether? If not, how can I control the risk to that harm is unlikely? The simple things, redesign the job, replacing the material, machinery, or process, organizing your work to reduce exposure to the material, machinery, process, providing personal protective equipment, and make sure or monitor if they use it. If you need a further control, consider we have to also to ask ourselves what risk control strategy are most applicable for the resources available. Are resources sufficient to obtain and maintain those risk control measures? Are proposed control strategy effective, sustainable, and achievable, and so on. Then identify and implementing the practical measures need to work safely, both in the both controls you have identified in place. انه once to you are يعني put the control you in the place, you are not expected to eliminate all risk, but you need to do everything reasonable, practicable to protect people from the harm by balancing the level of risk against the measures need to control the real risk in the workplace. We come to the last or the third component, performance, started by record your finding and start to running the performance measurements and analysis of that data to ensuring the system is working the way it was designed. You must review the control you have put in place to make sure they are working. You must review the changes in the workplace that could lead to new risk. We call it residual risk, such as changes in activities or biological agents, personal equipment, facility. Sorry to say we must, but this is the nature of our, this is the nature of the biorisk management. We have to be strict, tough to establish the, or to implement the program. You must establish periodic review, the cycle process for continual improvement, the system. Is it clear, this slide?
Yes, proceed,
Okay.
please.
Effective management system approach should have to be or should be built on the concept of continual improvement through the 4 stage of Deming cycle method, we call BDCA, and also by selecting the appropriate international standard within the national standard to get a good example of management system. Simple questions. What is the BDCA? BDCA, it's stand for plan, do, check, and act, as you see. It is a method used for continuous improvement of process produced by business. But I want to talk about the history of this method. I would like to mention what is the main goal of using, because this method, it's need a separate session to see how to implement it in biorisk management. The main goal of using the Deming cycle, it is not only for only the continuous improvement of process and product, but also to maintain control and to continuous improve them. Keep in your mind a bad system will beat a good person every time. The 4 stage planning, the 4 stage of Deming cycle, planning, implementing, checking, and reviewing. We will talk in details in the next slide. Biorisk management system, all aspects of BDCA cycle have to be addressed through the structure approach for achieving objectives and goals based on identify tasks and controls, define role and responsibility, documented for reference and change control, competence requirements including ongoing development, record of control and how to protect that record, competency and performance. How to implement Deming cycle in for biorisk management system, started by planning, define the specific biorisk program objective, ensuring the program its compliance with all national international requirements, effectively allocate limited resources to address a high risk first, and perform the risk assessment. To start the risk assessment, we have to have a biorisk policies, biosafety officers, biosafety committee, started by using different methods. One of that method, we call it risk matrix, is a common method, mainly not only used for assessing the initial risk, but also it could be used for ongoing monitoring and review of risk through the life of BMS. and for assessing the initial risk level by measure both likelihood and total impact of if it were to be happen, and classify the risk to unacceptable, as you see for the red color. Stop at that level. We have to stop activity, make immediate improvement, and tolerable, the other color, to look to improve within a specific time scale. Adequate, look to improve at next review, and lastly, acceptable. In this, no further action needed, but ensure control are maintained. It is important also to acknowledge that all the time there will be never be zero risk unless the work is not conducted at all. So balance must be carefully managed between conducting the work and controlling the biorisk. The total or the outcome of that result of the risk assessment, it will directly affect the quality of the risk mitigation decision to select the appropriate equipments required. We come now to the second step or second stage: do determine rules and responsibility, provide standard training. Biorisk manual have to have a safe work practice, good standard operation procedure, and competences. Provide personal knowledge and skill, hazard coverage, hazard identification, biorisk assessment, and biorisk control. Have to implement risk mitigation or implement the risk mitigation measures, perform facility maintenance, facility design, safety equipment, emergency response, and contingency plan. This is the highly important, especially in the health care organization. Occupational health program, this is totally negligible in most organizations. Waste management, record documents, and data control. Check. We have to, biorisk management program must be documented. Documents need to be reviewed for analysis, evaluation, and updated at regular interval and after any incident as a part of performance measurement stage. Regular audits and internal and external inspection are vital tools to assess the program efficiency and evaluate the opportunities for improvement. We come to the last stage. This is a stage we call it started and ended stage. Started, the biorisk management program should be regularly reviewed and updated. Review information should be include audit results, work activities, status of risk assessment activity, status of preventive corrective action, follow-up action from previous management review, result of incident investigation, changes that could be impact the program have to be a review should be lead to a decision and action to improve the BMS. International, we have here a comprehensive references. We have the international comprehensive references for biorisk management system. It could be, we should, the first of all, to differentiate between what is the guidelines and what is the standard. The guidelines, it should be used all the time to help, to advise about how to something or about how to deal with problems connected with your work. education, or personal relationship. For example, of that guidelines, laboratory safety manual for WHO, biosafety in microbiology and biomedical CDC, and so on. Whereas the standard, it's something else, totally something different. It should be, it's something set up and established or to established by authorities as a rule for the measures of quantity, weight, extent, value, or equality. Example here, we have CNN workshop agreement. CNN, it's abbreviation for European Standardized Committee Workshop Agreement Standard. This standard, they call it Laboratory Biorisk Management Standard, or have the international name CWA 15793, Laboratory Biorisk Management Standard. The importance of that this standard has been produced through the mechanism whereby stakeholders can bring their standardization and specification requirement and develop a result by consensus validated in open process. The purpose of this standard improve overall the laboratory biorisk performance, increasing awareness of biosafety, biosecurity risk, effective management of complex laboratory safety, security process, improving the international laboratory collaboration and safety harmonization. Basis for new or review legislation and regulation, support laboratory certification, accreditation, audit, and inspection. Scope of the standard, definitely it's not a technical document. The standard is performance oriented, describe what need to be achieved and how to do it. It is up to the organization. The standard is not intended to replace any national or subnational regulatory requirement that may apply to the laboratory or related facility. Compliance with regulatory requirement is mandatory. Example of the topics included in that standard is biorisk management policies, how to make the policies, hazard identification, training, operational control, and ended by biorisk management review. We come to the next standard, international standard, ISO 35001, biorisk, they call it biorisk management for laboratories and other related organizations. Actually, the importance of this standard, it is the first internationally recognized management standard to specifically address hazard associated with the laboratory where biological material are handled at all containment level. It set out the requirement for management system to enable organization to effectively identify, monitor, and control the risk association with laboratory biosafety and biosecurity. And also, it is also provide a structured approach to management, to managing a risk associated with people, facility, and working procedure in laboratory environments. The purpose of did a mistake. The purpose of the ISO established the biorisk management principle that enable laboratories and related facility to achieve their biosafety and biosecurity objective, define the essential component of biorisk management system framework, describe a comprehensive biorisk management process that mitigate a biorisk biosafety and biosecurity, provide a guidance on the implementation and use of the standard, where appropriate. We come to the end, the conclusion. The first important, the biorisk management is essential for biosafety and biosecurity. Consideration should be given to the AMP approach to help ensure the biorisk management system are well designed based on the risk assessment, sustainable, implemented, or keep in your mind, implemented effectively and efficiently, saving time and money. Continued implement of continual improvement and corrective action program. It will lead to the biorisk management program performance above the standard requirement. Encourage active participation by all stakeholders in biorisk management, facilitate the implementation of the AMP biorisk management models, and adaptation and implementation of the CNN workshop agreement 15793, promote a common standard for biorisk management system. We come now to the reference, as you see here. Thank you very much for giving me this opportunity. And I would like to say thank you to the chairman, my brother Abdul Qadir, and what they call the scientific committee, Mr. Riham, Dr. Ahmed, and Mr. Ahmed Sayed, and also our colleagues in King Abdulaziz, Riyadh, King Abdulaziz Medical City, the educational manager, Mr. Amir Al-Hamidan. Thank you for very much for your listening. And now the theater is yours. If you have any question or comments or suggestion for the next event, you are most welcome.
Thank you very much, Mr. Ahmed, for this informative session on biorisk management. Ladies and gentlemen, please, if you have question or comment, please raise your hand so I'm able to unmute your mic, or please write your questions in the chat box. Thank you again. Thank you, Mr. Ahmed. Very
You are
informative.
most welcome.
Right, 10 more seconds to receive questions. If you do have a question, please don't hesitate. You are welcome to contact us through the WhatsApp number or the email given to you in the email registration you received. All right, thank you, Mr. Ahmed, and thank you all for attending this session, the first scientific clubs meeting of the SSCH. We hope to see you again.
Inshallah.
You do have a lovely night. Thank you for attending. God bless you all.
Thank you for you.